Assalamu alaikum. Now, video station of DKA or Kusmo breathing. The video, I can say a 13 years old boy who is in hospital settings looking anxious, alert, and not he is not non-dysmorphic, and monitor is attached, and he has deep labored breathing, mainly the abdominal, most probably the too small breathing. So, what may be the cause of this too small breathing? We can remember by too small, K for the ketoacidosis, U for the uremia or kidney cause, S for sepsis, M for methanol, A for aldehyde, L for lactic acid. So, the differential diagnosis, ketosis, easily we can memorize in this way. Too small. K for ketosis, U for uremia, or kidney disease is for sepsis, M for methanol, A for aldehyde, L for lactic acid. So, what history you will want to ask if it's a case of decay, or so onset, um, and course progression, and is he has a known case of diabetes, or it is the initial presentation. If it is the initial presentation, so any history of polyuria, polydipsia, any weight loss, any what's about the activity, any abdominal pain, any convulsion, any heat or cold intolerance, any skin change, any joint problem, any vomiting, what's about the bowel history, and in family history, positive family history present or not, and in skin, is there is skin pigmentation present or not, social history, and but if it is a previously diagnosed case of diabetes, so when it was diagnosed, how frequently decay episode occurred, what was the level of admission, and detailed history of insulin, types of insulin, storage, how to use it, who gave the insulin, what about the diary, ketone monitoring, last hemoglobin A1C, compliance with the team, dietary history, what's about the exercise, and what is the impact, is any school bullying, what the team member, if he is regularly follow up or not. This is the detailed history. And now, if it is a case of DKA, so what examination? Examination, first of all, the vital sign, respiratory rate, heart rate, blood pressure, pulse volume, dehydration status, sign of cerebral edema present or not, such as the papilloedema, small or irregular pupils, high blood pressure. Is there any sign of infection? Is that associated any condition or compliance, such as height and weight of the baby? And then what investigation? So we can memorize, I try to memorize in this way to establish the diagnosis, CBG, ketone body, blood gas analysis, and kit electrolytes. To rule out the infection, full blood count, blood urine culture. Previous diabetic is to see the previous diabetes status, hemoglobin A1C. If meningism, LP, liver function test. And if it is a newly diagnosed case, so we have to send at the same time glutamic acid decarboxylase antibody, islet cell antibody, thyroid antibody, thyroid function test, celiac antibody, and immunoglobulin A level. And how will you manage the case? So for the management, we will first manage the airway, breathing, circulation, and monitor the vital sign. Admission, if the patient is alert and not shocked, so general H2 admission. But if the unconscious is less than 8 or shocked, so PICU admission. and involve senior consultant. And if when we consider the shock, when there is weak steady pulse hypotension, and if there is a shock, then 20 ml per kg, 0.9% sodium chloride over 15 minutes. But if it is not shock, so 10 ml per kg over 30 minutes. Management starts from the IV fluid. Number 2, insulin. Number 3, monitoring. Number 4, management of the cerebral edema, and their subsequent blood glucose monitoring, further management. So first of all, the IV fluid, as shock, if shock, if not shock, and then we will use sodium chloride, 0.9% with 20 millimole potassium chloride in every 500 ml, with insulin points, with the start insulin, and we will monitor. And this is the insulin infusion, and the monitor we will check the hourly blood glucose and the neurological status, and management cerebral edema if present. And whenever the blood glucose level comes around 14, so we will in the fluid we will add 5% glucose. And for further management, when the child will is stable, we will convert to the subcutaneous insulin and inform the diabetic team, and arrange OPD follow-up, and advice, support, and education and action plan. And this all about the DKA station. Thank you.